Hello, my name is Bradley Reeves. I'm one of the orthopedic surgery interns. Today, I'll be presenting a study out of Children's Hospital, Colorado, entitled Correction of Leg Length Discrepancy and ACL Instability in Fibular Hemimelia, Technique for an Effective Combined Approach with Precise Nail. Fibular hemimelia is classified as congenital deficiency of the fibula and is commonly associated with hypoplasia or dysplasia of the ipsilateral femur, tibia, and/or foot. Hemimelia remains one of the most common congenital long bone deficiencies, with a variable incidence reported between 5.7 to 20 cases per 1 million live births. Traditionally, the significant congenital leg length discrepancy seen in hemimelia were treated with bone lengthening procedures utilizing external fixation methods or intramedullary lengthening nails, often in combination with ipsilateral or contralateral epiphysiodesis. More recently, externally controlled internal lengthening motorized devices, such as the PRECICE nail, have been recognized as reliable and safe means to achieve accurate lower extremity long bone lengthening. Despite this advancement in limb lengthening, fibular hemimelia is associated with several extremity malformations that require careful consideration and may prompt additional intervention. These include lateral femoral condyle hypoplasia, genu valga, tarsal coalition, cleft foot, ball and socket type ankle, and anterior cruciate ligament deficiency. While ACL deficiency has an incidence of up to 95% in patients with hemimelia, the importance and feasibility of ACL reconstruction in this challenging pediatric population has remained up for debate. This study offers a technique and clinical outcomes of pediatric patients with hemimelia who underwent either femoral or tibial lengthening with magnetic motorized nails and concomitant ACL reconstruction. The aim of the study is to guide successful treatment of knee instability and leg length discrepancy in patients with hemimelia. The first specific aim is to demonstrate adequate lengthening and acceptable correction of leg length discrepancy with utilization of PRECICE nails specifically. The second aim is to detail a surgical technique for ACL reconstruction in patients who underwent either femoral or tibial lengthening with a PRECICE nail. And the third aim is to compare clinical outcomes in patients with fibular hemimelia who underwent limb lengthening and ACL reconstruction surgery. This is a single institution case series that includes 5 patients. The study subjects are patients with congenital fibular hemimelia who underwent limb lengthening via magnetic motorized nail implantation of either the femur or tibia with ACL reconstruction at Children's Hospital, Colorado between 2012 and 2022. Inclusion criteria included patients who were less than 18 years of age with fibular hemimelia, congenitally shortened tibia and/or femur, an ACL deficient knee, and use of PRECICE nail who underwent ACL reconstruction. Data collection was done through chart review in the EPICS EHR. Lower extremity limb lengths were obtained from calibrated standing hip to ankle x-rays using EPIC PAC system, and measurements were taken from x-rays preoperatively and postoperatively up to 4 years out from surgery. Significant leg length discrepancy was characterized as an inequality of greater than or equal to 2 centimeters. Knee instability was defined as subjective symptoms of instability with at least grade 2 pivot shift and grade 2A Lockman's test on physical exam. Analysis was descriptive only. Looking at the technique for this procedure, ACL reconstruction was commenced prior to the guided growth portion of the surgery for either congenital short femur or congenitally shortened tibia. 3 standard arthroscopic portals were established, and ACL deficiency was confirmed by direct visualization. As demonstrated in Figure 1 and Figure 2, ACL reconstruction was accomplished by either physeal sparing reconstruction via iliotibial band graft or quadriceps tendon autograft. For reconstruction with iliotibial band graft, an incision is made over the lateral aspect of the distal femur, extending from just proximal to Gerdy's tubercle, 3 to 4 centimeters proximally. Dissection is taken down to the iliotibial band, which is then incised longitudinally to make a 2 centimeter wide by 20 centimeter long graft with the distal attachment at Gerdy's tubercle still intact. The graft is then tubularized via whip stitch and with arthroscopic guidance, passed over the top of the lateral femoral condyle, through the femoral notch, and retrieved out the medial portal. The graft is then tensioned with the knee in neutral rotation and flexed to 90 degrees and sutured to the lateral femoral periosteum and surrounding soft tissues. In the case of the quadriceps tendon autograft, the graft is harvested with a bone plug from the mid portion of the proximal pole of the patella, tubularized, and passed through drilled femoral and tibial tunnels. The graft is secured proximally with the bone plug in the distal femoral tunnel, and the sutures and graft are passed through the tibial tunnel and provisionally secured in place. At this time, prior to completing the final tibial fixation portion of the ACL reconstruction, the PRECICE nail is placed. As demonstrated in figures 3 and figures 4, in cases of congenital short femur, a great trochanteric internail approach is used. The osteotomy site is prepared approximately 9 centimeters distal to the tip of the greater trochanter with several 3.5 millimeter vent holes. K-wire pins are driven into the femoral cortex, proximal and distal to the osteotomy site to facilitate rotational control while the osteotomy is completed, nail advanced, and interlocked into position both proximally and distally. Also, the iliotibial band is identified distally through the osteotomy incision and completely transected. For congenital short tibia, osteotomy is planned approximately 7 to 10 centimeters below the level of the joint line. An incision is made just lateral to the tibial crest, and the tibia is vented, again with a 3.5 millimeter drill. The lateral arthroscopy portal is lengthened distally to expose the proximal tibia. A guide pin is placed into the proximal tibia, just anterior and medial to the lateral tibial spine, and under fluoroscopic control, the physis is visualized and reamed 1 centimeter, and the tibia is reamed 1 centimeter below the level of the physis. Prior to the fibular osteotomy, the syndesmosis is fixed utilizing a 3.5 millimeter screw spanning from the fibula into the tibia 2 to 3 centimeters proximal to the distal tibial physis. At the level of the junction of the middle and distal thirds of the fibula, an oscillating saw is utilized to cut the fibula obliquely in a proximal posterior to distal anterior direction. The tibial osteotomy is then completed, the nail advanced distally to within 2 to 3 centimeters proximal to the level of the syndesmosis fixation screw, and locked into place both proximally and distally. Once the PRECICE nail is in place, the ACL reconstruction is then completed. For iliotibial band grafts, a rasp is used to remove sharp bony transitions and build a trough in the ACL footprint, extending to the proximal anterior tibial cortex. The IT band is then passed under the intrameniscal ligament, and with the knee flexed 30 degrees, the graft is tensioned and sutured into the periosteum of the proximal anterior tibial cortex. Additionally, a push-lock suture anchor is placed just distal to this suture attachment for additional reinforcement. In cases of quadriceps tendon autograft, the graft is tensioned and secured to the proximal tibia with a button. Postoperatively, a hinge knee brace locked in extension is applied. Patients are given modified weight-bearing restrictions, and the nail is advanced at a rate of 0.3 millimeters per day until a goal lengthening is achieved or the nail is fully extended. The average age of presentation to Children's Hospital Colorado for patients with hemimelia was 1 year and 3 months. Detection of associated anomalies and disease monitoring was performed with routine follow-up appointments, approximately 6 months to 1 year out, which included serial exams and interval radiographs. 4 or 5 patients underwent ipsilateral hemiepiphyseal of the distal femur to facilitate correction of knee alignment between the time they're identified of having hemimelia and undergoing leg lengthening and ACL reconstruction surgery. With maturation and participation in more vigorous activities, patients were screened for involvement in sports for subjective symptoms of knee instability. All 5 patients reported subjective symptoms of knee instability and underwent MRI, which demonstrated ACL deficiency. Figure 2 outlines a typical patient course who has fibular hemimelia and undergoes leg lengthening surgery at Children's Hospital Colorado. This is a 14-year-old male with left fibular hemimelia and left tibial hypoplasia with congenital leg length discrepancy and ACL deficiency. The patient initially presented at 2 months of age with fibular hypoplasia and 2.8 centimeters of shortening of the left lower extremity compared to the right. Final preoperative x-rays done at 11 years and 7 months of age demonstrated progression of the leg length discrepancy to 3.5 centimeters of shortening of the left compared to the right. MRI was completed prior to operative intervention, which was done at 9 years and 2 months of age and demonstrated absence of the ACL. Initial postoperative left lower extremity x-rays at 11 years and 8 months of age demonstrated medial distal femoral hemiepiphyseodesis, PRECICE nail with tibial and fibular osteotomies, syndesmosis screw fixation, and ACL reconstruction. Final controlled lengthening of the lower extremity was observed with x-rays at 11 years and 11 months of age after 5 centimeters of controlled left tibial lengthening, which resulted in a positive 0.6 centimeters of lengthening of the left lower extremity as compared to the right. At the time of the last postoperative follow-up visit for this patient, which was when the patient was 13 years and 3 months of age, the right lower extremity was noted to be 1.3 centimeters longer than the afflicted left lower extremity. Looking at our cohort of 5 patients, the average age at the time of surgery was noted to be 10.5 years. The average total preoperative leg length discrepancy was noted to be 4.22 centimeters, with average preoperative femoral leg length discrepancy of 1.56 centimeters and average preoperative tibial leg length discrepancy of 2.66 centimeters. On average, femoral guided growth resulted in lengthening of 6.95 centimeters, and tibial guided growth resulted in lengthening of 5 centimeters, which is the maximum lengthening for the tibial PRECICE nail. Overall residual leg length discrepancy following guided growth was 2.56 centimeters, with an average follow-up time of 2.2 years. PRECICE nail-related limb lengthening complications included 2 patients with early fibular consolidation and 1 patient with knee arthrofibrosis. All 3 of these patients required additional operative management for repeat fibular osteotomy and closed manipulation, respectively. ACL reconstruction with either physeal sparing iliotibial band construct or quadriceps tendon autograft reported subjective and objective knee stability at follow-up and were able to return to sport if they were engaged prior to surgery. In conclusion, PRECICE nails provide reliable guided limb lengthening. Although our study did note that there was persistent and clinically significant leg length discrepancy at the time of the final post-op visit, it's not uncommon following leg length discrepancy, and it is possible to achieve additional leg lengthening through further guided intramedullary lengthening surgeries, external fixation type surgeries, or epiphyseodesis of the contralateral leg for growth arrest. ACL reconstruction was demonstrated to be routinely feasible at the time of externally controlled internal lengthening motorized magnetic intramedullary nail insertion with good stabilization of subjectively and clinically unstable knees. With regards to future directions for this study, I believe that it would be beneficial to include subjective patient-reported outcomes in combination with clinical outcome data. And it would also be interesting to do a comparison of the titanium PRECICE nails that were utilized in this study with the newer stainless steel stride nails that allow for greater weight bearing. I'd like to thank Drs. Roper, Albright, and Miller, as well as Rita Sultan, for allowing me to participate in this study and for all of their help in completing it. Thank you all for listening, and I hope you have a great rest of your day. Thank you.